All right, welcome everyone. Today we're diving into a topic that is just so central to our daily work in psychiatry, appetite. But look, we're not just talking about feeling hungry or full. We're going to frame appetite for what it really is, which is a complex, brain-driven motivational state. I mean, think about it. It's a core symptom in so many conditions we treat, and it's this final common pathway for mood, for stress, and maybe most importantly, for our medications. So let's kick things off with a clinical puzzle I'm sure you've all seen. So here it is. This is the big question we're here to solve today. It's a scenario we see all the time, right? A patient's appetite just seems to swing from one extreme to the other, all depending on their illness and our treatments. Figuring out the why behind this isn't just some academic thing, it's absolutely fundamental to giving better care. And I promise you, by the end of this explainer, the neurobiology behind this is going to be crystal clear.
So the key to cracking this puzzle is realizing that appetite isn't just one single thing. Nope, it's actually the result of this constant battle for control between two very distinct, very powerful, and often competing systems inside the brain.
So on one side, you've got the homeostatic system. Think of this as the body's meticulous accountant, It's all business. It only cares about energy balance. It's the system that drives you to eat when you need fuel and tells you, okay, stop when you're full. But then you have the hedonic system. This is the fun one. It's all about reward, pleasure, and craving. It's the reason you can be completely stuffed after dinner but still want dessert. It really is the need to eat versus the want to eat. And in psychiatry, that distinction is everything.
To help us keep track of all this, we're going to use this simple mental map. The hypothalamus, that's our hub for homeostasis, the need to eat. The limbic system is the engine for that hedonic, reward-driven want to eat. And then you've got the prefrontal cortex, which is like the executive control center, trying to manage the whole show. It's the dynamic push and pull between these three areas that dictates literally every decision we make about food.
So let's start with that homeostatic hub, the brain's main hunger switchboard, the hypothalamus. This is ground zero for where those fundamental need-to-eat signals get processed. Okay, so deep inside the hypothalamus, there's this critical little area called the arcuate nucleus. You can really just think of it as the master control panel for appetite. It's constantly getting updates from the body about your energy levels, and it's its job to decide whether to flip the hunger switch on or off. Now, what's so cool is how this switch actually works. It's a classic push-pull system. So on one side, you have these NPY/AGRP neurons. When you haven't eaten in a while, these things fire like crazy and basically scream, go eat. They are powerfully orexigenic, that just means appetite stimulating. And then on the other side, you have POMC/CART neurons. After a meal, they fire up and send the signal, stop eating. They're anorexigenic, or appetite suppressing. It's all about keeping this delicate balance. So how does the arcuate nucleus even know when to flip that switch? Well, it's not just guessing. It's in constant communication with the rest of your body, listening to the stream of hormonal messages coming from your gut and even your fat tissue. And this table here shows the key players in that conversation. Now notice a pattern. Ghrelin, which comes from an empty stomach, is pretty much the only major hormone that screams, eat. It's the main driver of hunger. Almost everything else, leptin from our fat stores, insulin from the pancreas, all these other gut peptides, they're all satiety signals. They're all telling the brain, hey, we're good down here, you can stop now. Okay, so that's the homeostatic system. Pretty straightforward, right? But if that was the whole story, nobody would ever eat when they weren't physically hungry. To really get the full picture, we have to talk about the powerful influence of reward, craving, and the part of the brain that tries to keep it all in check. So at the very heart of this hedonic or reward system is the mesolimbic dopamine pathway. This is the brain's core motivation circuit. So when you see, a delicious-looking piece of cake, your VTA gets activated. It then sends a signal to the nucleus accumbens, and boom, you get a surge of dopamine. And it's that dopamine surge that drives the motivation, that makes you want to go get that piece of cake. Now, this is a really crucial point. Dopamine is not about the pleasure of actually eating the cake. It's about the motivation to get it. It's the craving, the anticipation, the wanting. The actual pleasure you get from it, the liking, that's mediated more by the brain's opioid system. And this separation is so key to understanding things like binge eating, where that drive to eat can get completely uncoupled from any real sense of enjoyment. So if the limbic system is the accelerator for wanting, then the prefrontal cortex, or the PFC, is the brakes. This is the part of your brain that's in charge of executive control, the part that says,
you know what, maybe I shouldn't have that second slice of cake. It's what allows us to delay gratification. And crucially for us, we know that in conditions like depression and ADHD, the function of these PFC brakes can be seriously impaired. So, now we've got all the pieces on the board. We've got the homeostatic need, the hedonic want, and the cortical control. So let's see how the very medications we prescribe can systematically hijack these exact pathways. Okay, so for a lot of the second-generation antipsychotics, they cause weight gain through two main mechanisms. First, by blocking the histamine H1 receptor, they essentially cut the brake lines on satiety signals. Your brain just doesn't get the message that you're full. Second, by blocking the serotonin 5-HT2C receptor, they remove an inhibitory signal that was holding back those go-eat NPY/AGRP neurons. So it's like putting a brick on the accelerator. It's a really powerful 1-2 punch that messes with the homeostatic system. And this brings us to what might be the single most important clinical pearl in this entire explainer. When a patient gains weight on these medications, it is not a failure of their character or their willpower. It is a direct, predictable neurobiological consequence of that medication hijacking their brain's appetite circuitry. And just reframing it that way can totally transform the conversations we have with our patients. All right, so with this whole framework in mind, homeostatic, hedonic, and pharmacological, let's circle all the way back to our original question and finally solve this puzzle. Here it is again. How can appetite shift so dramatically in the same exact person? Well, the answer is that the illness and the treatment are hitting completely different parts of the system. See, in depression, the loss of appetite is often driven by anhedonia, which just crushes that dopamine-driven wanting system. Food just doesn't seem rewarding anymore. At the same time, all that chronic stress and inflammation can actually suppress the homeostatic drive to eat. But then, we come in and introduce an antipsychotic. This medication basically bypasses the mood state and goes straight for the homeostatic machinery in the hypothalamus, blocking satiety and cranking up that go-eat signal. So now, the patient feels this powerful primal hunger that has almost nothing to do with their mood or pleasure. So, to wrap it all up, here are the 5 main principles to take with you into your practice. 1. Appetite is controlled by the brain. 2. The need to eat and the want to eat are 2 different things. 3. Our patients' illnesses directly change these brain circuits. 4. Our medications do too, and often in very powerful ways. And finally, number 5. To manage any of this effectively, we have to start with this brain-based understanding. And that brings us to the final and most crucial question. And this one is for you to think about. Now that you can actually visualize the circuits that are being hijacked, how is this going to change the way you talk about appetite, about food, and about weight with your very next patient?